Every week, patients sit across from me convinced they are doing everything right. They bought the shoes recommended for seniors, thick soles, deep cushioning, and yet they arrive with knee pain that did not exist 6 months ago, a heel that burns with the first step of the morning, a lower back that locks up by the third block. The question I ask is always the same. Let me see the shoes. What I find almost every time explains everything. Subscribe and hit like right now. What you are about to hear, no one will tell you at your next appointment. The system profits when you stay in pain, not when you walk without it. Help Dr. Arthur Whitmore reach 100,000 subscribers. Here is what is actually happening inside that foot after 50, and why the answer is not as simple as the packaging claims. The first change is one almost nobody warns you about. The fat pads on the soles of your feet begin to thin. These are not incidental tissue. They are your body's primary shock absorption system at the exact point of ground contact. A young foot lands on a thick, resilient layer of adipose tissue, that is fat cells arranged in a specialized fibrous matrix, engineered specifically to compress under load and rebound. After 50, that matrix degrades. The cells thin out. The fibrous structure loses its elasticity. The pad that once measured several millimeters shrinks toward 1 or 2. This is not a disease. It is a predictable, measurable consequence of aging that affects virtually every person over 50 to some degree. And when that cushioning diminishes, every ground impact travels upward through the skeletal chain without adequate absorption. The ankle receives it first, then the knee, then the hip, then the lumbar spine, the lower portion of your backbone. The foot was designed to handle that impact so the joints above it would not have to. When the foot can no longer do that job, the joints above it absorb load they were never designed to manage at that volume. The second change is the decline of the intrinsic foot muscles. These are the small muscles that live entirely within the foot itself, as opposed to the extrinsic muscles, which originate in the lower leg and send tendons downward. The intrinsic muscles do several things most people never consider. They maintain the shape of the arch under dynamic load. They control the spread and grip of the toes during the push-off phase of each step. And critically, they generate proprioceptive feedback, that is the continuous stream of sensory information telling your nervous system exactly how the foot is oriented, how much pressure sits under each region, and how to adjust balance in real time. When intrinsic muscle strength declines, that feedback signal weakens. The arch loses its active support. The toes lose their grip. Your nervous system begins operating with less precise information about what your foot is doing beneath you. People experience this as a vague instability underfoot, a slight unreliability on uneven surfaces, a habit of looking down while walking rather than ahead. It is not imagination. It is a measurable loss of sensory and structural function. The third change follows directly from the second. When the intrinsic muscles weaken and can no longer hold the arch under load, the arch begins to flatten. This is called acquired flat foot, and it is distinct from the congenital flat foot some people are born with. As the arch drops, the mechanical axis of the entire leg shifts. The knee begins to track inward, a position called valgus, which increases compression on the medial compartment of the knee joint, that is the inner surface where the thigh bone meets the shin bone. The hip rotates to compensate. The pelvis tilts. The lumbar spine absorbs the resulting asymmetry with every step. This is why a patient arrives describing knee pain and hip tightness, and the origin of the problem is in the foot. Not the knee, not the hip, the arch. The fourth change is the decline of proprioception itself, independent of muscle weakness. The sensory receptors in the skin of the sole, in the joint capsules of the ankle and midfoot, and in the tendons of the foot lose sensitivity gradually after 50. This is a normal neurological process. What it means practically is that your foot provides your brain with a less detailed map of the ground surface beneath you. On smooth pavement, this goes largely unnoticed. On uneven surfaces, on wet ground, on a slightly raised threshold, the deficit becomes significant. Balance corrections happen more slowly. The risk of a fall increases. And here is the critical point that no one in a shoe store will tell you. Walking addresses all four of these systems at once, but only when the foot doing the walking is properly supported and properly trained. That distinction is exactly where the controversy begins. Two industries have looked at these four changes and arrived at opposite prescriptions. The maximalist shoe movement, thick foam midsoles, aggressive arch support, deep heel cups, argues that since the foot's natural cushioning and structural support have declined, the shoe must replace them. More foam, more structure, more protection. The barefoot and minimalist movement argues that precisely because the foot's muscles and sensory systems are declining, the solution is to reactivate them by removing artificial support and allowing the foot to do what it was designed to do. Less foam, less structure, more sensory contact with the ground. Both positions have clinical evidence behind them. Both have produced real improvement in real patients. And both, applied incorrectly, have caused serious harm. The person standing in a shoe store at 53, reading two contradictory sets of claims on two adjacent boxes, is not confused because they failed to research the topic. They are confused because the question is genuinely more complex than either box admits. That complexity is exactly what the rest of this addresses. The case for maximalist cushioning is not without foundation, and it is important to establish that clearly before examining what goes wrong. People assume I am against cushioned shoes. That is the wrong conclusion. The clinical picture is more precise than that. When the fat pads of the sole have thinned significantly, a thick foam midsole, that is, the layer of compressed material between the outer rubber sole and the inner lining of the shoe, does absorb a meaningful portion of ground impact. Studies measuring ground reaction force, the upward force the ground exerts on the body with each step, confirm that cushioned footwear reduces peak impact in the short term. For a patient with severely thinned fat pads and already compromised cartilage in the knee, that reduction is not trivial. It is pain relief. That is why maximalist shoes became popular with the 50-plus demographic in the first place. They work in the immediate symptomatic sense. The problem is what happens over months and years of exclusive reliance on that cushioning. When a joint is immobilized in a cast, the muscles surrounding it atrophy. This is not a side effect. It is a direct consequence of removing the mechanical demand that keeps muscle fibers active and strong. The intrinsic muscles of the foot operate on exactly the same principle. They maintain their strength and their sensory acuity because the foot is loaded, compressed, and required to respond to ground variation with every step. When a thick, rigid midsole and a deep arch support structure absorb that variation before it reaches the foot, the intrinsic muscles receive a reduced signal. Load them less, and they strengthen less. Over time, they weaken. The arch support built into most maximalist senior footwear accelerates this process in a specific way. The medial longitudinal arch, the curved inner structure running from the heel to the ball of the foot, is maintained dynamically by the intrinsic muscles and the plantar fascia, a thick band of connective tissue running along the underside of the foot, working together under load. A rigid arch support holds that arch in position mechanically, removing the need for the muscles to do it actively. The muscles receive the message that their contribution is not required. Over months, they provide less of it. The arch that the shoe was supporting becomes structurally dependent on that support. Remove the shoe, and the arch collapses faster than it would have without it. The consequence chain is specific and measurable. Weakened intrinsic muscles allow the arch to drop under load. The dropped arch shifts the knee into valgus alignment. The medial compartment of the knee absorbs increased compression. The hip compensates with internal rotation. The lower back responds with asymmetric loading. The patient reports knee pain and is prescribed more arch support. The cycle tightens. Now consider the barefoot argument. Minimalist footwear removes the foam and the arch support structure, placing the sole of the foot in close contact with the ground surface. The sensory receptors in the skin and joint capsules receive a richer stream of information. The intrinsic muscles are required to maintain the arch actively under every step. Proprioceptive feedback improves. Over time, foot muscle strength increases, arch integrity improves, and the mechanical chain upstream stabilizes. The clinical evidence for this outcome is real. It has been reproduced across multiple study populations. But the evidence documents with equal clarity what happens when the transition is abrupt. The plantar fascia and the Achilles tendon, the large tendon connecting the calf muscles to the heel bone, are structures adapted to the specific load pattern they regularly experience. In a cushioned shoe with heel elevation, that is, the slight rise built into almost all conventional footwear, positioning the heel higher than the toes, the Achilles tendon operates in a shortened position. The plantar fascia operates with reduced tension because the arch support is managing part of its job. Switch abruptly to a flat, minimalist shoe, and both structures are suddenly required to lengthen under load and absorb forces they have not been conditioned for. The plantar fascia responds with inflammation at its insertion point on the heel bone. This is plantar fasciitis. The morning pain it produces, that sharp burning sensation with the first steps out of bed, is one of the most common injuries I see in patients who attempted an unsupervised shoe transition. The Achilles tendon responds with tightening and burning during and after walking that, if ignored, progresses to tendinopathy, a degenerative condition of the tendon tissue itself. Neither outcome is inevitable. Both are entirely predictable when the transition rate exceeds what the tissue can adapt to. People blame the minimalist shoe. That is the wrong conclusion. The shoe was not the problem. The rate of change was the problem. The reframe is this: the variable that determines outcome is not which shoe category you choose. It is the state of your foot musculature at the moment of the choice, and the rate at which you transition between loading demands. A foot with strong intrinsics and intact proprioception can tolerate a gradual shift toward minimalism and benefit from it measurably. A foot with severely weakened intrinsics moving abruptly into a flat shoe will be injured. A foot with thinned fat pads and early cartilage changes may genuinely need the cushioning a maximalist shoe provides, while the underlying muscular deficit is being addressed in parallel. The shoe is not the solution. The shoe is a temporary accommodation while the actual structural work is done. Subscribe and hit like if that distinction is one you have never heard explained in a clinic, because it should have been. Before any of that structural work begins, there is a more immediate problem most people are not aware of. The majority of patients I see who are damaging their joints with their footwear are not wearing the wrong category of shoe. They are wearing a dead one. Midsole foam is not permanent. The materials used in modern shoe midsoles, typically ethylene vinyl acetate or polyurethane foam, compress under load and are designed to rebound. Over hundreds of hours of use, that rebound capacity diminishes. The foam compresses and does not fully return to its original thickness. The cushioning that absorbed ground impact in month 1 absorbs significantly less of it in month 14. The shoe still looks functional. The upper fabric is intact. The outer rubber sole shows wear, but nothing alarming. The cushioning is largely gone. There is a simple test you can perform right now. Remove the shoe. Press your thumb firmly into the midsole, the layer of foam visible along the side of the shoe between the rubber bottom and the fabric upper. In a shoe with functional cushioning, the foam resists the pressure and rebounds when you release. In a shoe with fatigued midsole material, the foam compresses easily and returns slowly, or does not return at all. That slow, soft, unresisting compression is midsole fatigue. That shoe is no longer doing the job your foot requires. The second diagnostic is the wear pattern on the outer sole. Hold the shoe at eye level from behind and examine the heel. Uneven compression on one side means the foot is loading asymmetrically with every step. That asymmetry is traveling into the ankle, the knee, and the hip on every ground contact. It is not cosmetic. It is mechanical. The standard replacement threshold for a regularly used walking shoe is approximately 300 to 500 miles, or roughly 12 months of consistent daily walking, whichever comes first. The exterior will almost never signal this threshold visually. The midsole reaches it invisibly. This is not a commercial recommendation. It is basic joint protection. The transition between shoe types is where most of the damage happens, and it happens because people treat it as a decision rather than a protocol. They decide to switch. They buy the new shoe. They walk the same distance they walked the day before, in the same pattern, on the same surfaces. Within 2 to 3 weeks, they are in pain. They conclude the shoe was wrong for them. In most cases, the shoe was appropriate. The rate of change was not. Here is the protocol the clinical evidence supports. If you are moving from a maximalist or heavily cushioned shoe toward a lower support or minimalist shoe, the transition must be measured in increments of 10 minutes. Begin by wearing the new shoe for 10 minutes on the first day, during a walk you would otherwise complete in your existing footwear. Not 10 minutes of standing, 10 minutes of active walking. Then return to your existing shoe for the remainder. After 2 weeks at 10 minutes without symptoms, add 10 more minutes. Continue this progression, adding 10 minutes every 2 weeks until the new shoe accounts for the full duration of your walk. 2 weeks is not an arbitrary interval. It reflects the approximate time required for the plantar fascia and Achilles tendon to begin adapting to a new load pattern. Connective tissue, unlike muscle, has a limited blood supply and remodels slowly. Rushing the interval does not accelerate adaptation. It produces injury. There are 2 symptoms that mean stop and step back 1 stage. The first is plantar heel pain on the first steps of the morning. This is the signature presentation of plantar fasciitis, inflammation at the insertion point of the plantar fascia on the calcaneus, that is, the heel bone. It may ease after a few minutes of walking and return after prolonged rest. If it appears, reduce the new shoe increment by half and hold that duration for an additional 2 weeks before progressing again. The second symptom is Achilles tightness or burning during or immediately after a walk in the new shoe. This indicates the tendon is being loaded beyond its current adaptation capacity. The response is identical. Step back 1 stage. Reduce the duration. Give the tissue the time it is asking for. Neither symptom means the transition is wrong. It means the rate is wrong. Parallel to the transition protocol, and ideally begun 4 to 6 weeks before any shoe change, is the direct rehabilitation of the intrinsic foot muscles. 3 exercises address the primary deficits. The first is toe abduction, specifically the activation of the abductor hallucis, the muscle responsible for spreading the big toe away from the others. Sit with your foot flat on the floor. Without curling the toes or lifting the foot, attempt to spread all 5 toes apart and hold that spread for 5 seconds. Most people cannot do this deliberately on the first attempt. The motor connection to those muscles has become dormant from years inside shoes that hold the toes in a compressed position. Practice daily. Within 2 to 3 weeks, voluntary control begins to return. The second is the short foot exercise, sometimes called arch doming. Sit with your foot flat on the floor. Without curling the toes, draw the ball of the foot toward the heel, creating a dome shape in the arch. The toes remain straight and in contact with the ground. The contraction you feel in the arch is the intrinsic musculature engaging directly. Hold for 5 seconds. Release. Repeat 10 times per foot. This exercise trains the muscles responsible for maintaining arch integrity under the dynamic load of walking. The third is single leg balance on a varied surface. Stand on one foot on a folded towel, a yoga mat, or any slightly uneven surface for 30 seconds. The instability forces the intrinsic muscles and ankle stabilizers to respond continuously to postural variation, which is precisely the proprioceptive training these systems need after 50. 2 to 3 sessions per week of 30-second holds, progressing to 60 seconds as stability improves, produces measurable improvement in balance and sensory acuity within 6 to 8 weeks. These 3 exercises take less than 10 minutes combined. They address the underlying structural deficit that both the maximalist and minimalist camps are attempting to manage with footwear alone. The shoe cannot do this work. Only the foot can. Now, a clear practical conclusion. Here is exactly what to do after watching this. 1. Perform the midsole press test on your current walking shoes today. Press your thumb firmly into the foam along the side of the shoe. If it compresses without resistance and returns slowly, the shoe is functionally dead. Replace it regardless of how the exterior looks. 2. Examine the outer sole wear pattern. Hold the shoe at eye level from behind and look at the heel. Uneven wear on one side means asymmetric loading is traveling into your knee and hip on every single step. 3. If your shoes are more than 12 months old and you walk in them regularly, replace them. The midsole compression threshold arrives invisibly. The joint damage it permits accumulates the same way. 4. Begin the 3 intrinsic exercises now, before any shoe change. 4 to 6 weeks of daily practice prepares the foot musculature for whatever transition follows. Skipping this step is the primary reason shoe transitions fail. 5. If you are moving toward lower support footwear, follow the 10-minute increment protocol without shortcuts. 2 weeks per stage. Know the 2 warning symptoms and the precise response to each. A transition is a protocol, not a single decision made in a store. Here is what the shoe industry does not want openly discussed. The maximalist senior shoe category is one of the highest margin segments in athletic footwear. It targets a demographic that experiences real pain, responds to the promise of immediate cushioned relief, and replaces shoes less frequently than younger consumers, making per-unit margin more critical to the business model. The clinical reality that passive support accelerates the muscular atrophy driving the pain in the first place is not a message that moves product. Foot muscle rehabilitation requires no purchase. It requires 10 minutes and a floor. That is precisely the kind of information this channel exists to give you. What shoes are you currently walking in? Write the brand in the comments. I want to see the pattern across this audience because in 15 years of practice, the same brand names appear on the same feet with the same complaints. And that pattern is something you deserve to know about. Subscribe to Dr. Arthur Whitmore. Leave a like on this video. Help us reach 100,000 subscribers because the information in this video is the information that does not fit inside a standard appointment. The system profits from treatment. This channel exists for prevention.